everyone, and welcome to today's webinar. My name is Michelle Woodhill, and I'm the Senior Director of Development at Dr. Susan Love Foundation for Breast Cancer Research. For those of you who are joining us for the first time, I'd like to take an opportunity to introduce you to our organization. Dr. Susan Love Foundation challenges the status quo to end breast cancer through innovative research and improve the lives of people impacted through education and advocacy. We drive collaborative cutting-edge research with non-traditional partners, shed light on the collateral damage of treatment, and actively seek ways to diminish it and interpret science to empower breast cancer patients. Many of the projects the foundation undertakes are designed to increase our understanding of the human breast, where breast cancer starts, and what enables malignancy to occur, with the ultimate goal of developing methods to prevent it in the first place. The foundation is also committed to participation in research that has the potential to positively impact the lives of all people who are at risk for or who have breast cancer. Breast cancer happens in people, so research needs to be done on human beings, and that means men, women, non-binary people, everyone who gets breast cancer. Our Love Research Army is committed to encouraging and facilitating breast cancer research in all people, regardless of age, race, gender, sexual identity, with or without breast cancer diagnosis. We are committed to thoughtfully engaging our members by providing them with ongoing real-time access to an array of studies. Today's webinar is part of our patient education series, where we invite researchers and patient advocates to provide helpful resources and information for our patient community. Joining us today is Foundation Medical Advisor, Dr. Stephanie Graff. She is an accomplished physician who is board certified in medical oncology, hematology, and internal medicine. Dr. Graff has a strong background in cancer treatment. In addition to supporting the Dr. Susan Love Foundation, Dr. Graff is the Director of Breast Oncology at the Lifespan Cancer Institute at Brown University. While breast cancer treatment has advanced in many ways, it still comes with many side effects and toxicities, the collateral damage of breast cancer. Dr. Graff will now talk through some of the more common forms and strategies for management. Thank you so much, Dr. Graff. You're muted, Dr. Graff.
Got it. I was just trying to unmute. I'm excited to be here, and I'm going to be talking about the collateral damage of breast cancer treatment. Collateral damage is one of Dr. Love's phrases that I've stolen from her. So Dr. Love, thank you for the nomenclature. And I just moved to Brown from Kansas, so I've made this presentation Wizard of Oz theme. So I hope you all enjoy the Wizard of Oz references as we go through speaking about collateral damage. So hearts and brains and stomachs, oh my, there's so many side effects when we think about breast cancer treatment. And although we've come a long way in advancing breast cancer treatment, which has been small incremental advantages in terms of survival and outcomes for persons either diagnosed with early stage disease or living with metastatic disease, it means that there's still a lot of complications of that treatment that then they endure during treatment, and unfortunately in some situations lifelong afterwards. And I'm going to talk through some of those, including endocrine mediated side effects like hot flashes and night sweats, joint pain, where we'll reintroduce ourselves to the Tin Man, cardiopulmonary side effects like cardiomyopathy, neurologic side effects like peripheral neuropathy and Chemo Brain, where we'll visit our friend the straw man, GI side effects like nausea and diarrhea, and lastly, fatigue. That means that I am, however, leaving unsaid many side effects. Importantly, I'm leaving financial toxicity, social and emotional distress, sexual dysfunction, fluid retention, interstitial lung disease, weight changes, which I'm sorry to say is mostly weight gain in breast cancer treatment, immune-mediated side effects as breast cancer has entered the checkpoint inhibitor therapy era, bone loss, diarrhea, blood clots, pneumonia, including COVID-19, depression, anxiety, QT prolongation, and other arrhythmias are all going to be not discussed during my short presentation today. I feel like the foundation would have to invite me back for 100 other webinars so that we could talk about all the potential side effects. So moving right into hot flashes, we have the Wicked Witch melting here in the picture. The culprits of hot flashes and night sweats are largely our endocrine mediated treatments. So anastrozole, letrozole, exemestane, tamoxifen, Lupron and Grosserolin, which are both medicines that we use in premenopausal women to turn off ovarian function, fulvestrant, which is a medicine for metastatic breast cancer. And then any chemotherapy in a premenopausal woman essentially turns off ovary function as well and can cause night sweats and hot flashes. When I'm thinking, this is a mixed audience, I want to include pearls for clinicians as well as a patient audience. It's important as physicians when we're thinking about somebody who maybe has been on treatment for a while and never had hot flashes and now all of a sudden is having hot flashes, that we don't miss signs of infection or serotonin syndrome. Serotonin syndrome is a lot of our nausea medicines and some of our antidepressants all act on the serotonin cascade. And so when we use both the serotonin medicines and nausea medicines, antidepressants, sometimes we can build up too much serotonin in our system and it can present with a red hot flush face, drenching sweats, and it can cascade to a full-blown emergency. So it's important to think about that if you've started a bunch of new medicines recently. Treatment options of hot flashes and night sweats, there's a lot of things that we can do. Holistically, acupuncture has been shown effective. Meditation, CBT, which is cognitive behavioral therapy, and hypnosis have all been shown effective, but are all things that take time to develop those skills that you are controlling it, because essentially you're in all of those scenarios learning to control your mind, because so often hot flashes are being triggered by emotional triggers. So one of the things on that first list is also a trigger diary, where patients write down the things that are causing them to have hot flashes and looking for associations. Maybe it's when you're mad, maybe it's when you eat spicy foods, maybe it's when you drink alcohol. And then as you look to see what's triggering hot flashes, maybe there are things that you can avoid or minimize from your lifestyle in a way that decreases the number of hot flashes you're having. And maybe you decide that chocolate is worth having and you don't care about the hot flashes so much if it means you have to have a life without chocolate. Cooling products, of course, you can dress in light layers. You can buy all the fans in the world. They do sell cooling pillows, cooling mattress pad covers that are these like perpetually cool products that you can use as well. Then there's the medications that you can add. And sometimes I think patients get to a place where adding pills to treat your pills doesn't feel like a good direction for their care, but some patients, their hot flashes are bad enough that they want to take that step. The antidepressants, and particularly the SSRIs, so venlafaxine, citalopram, and escitalopram, are all effective at treating hot flashes. Of note, sertraline and fluoxetine are not effective. So sometimes somebody's on an antidepressant, then they start one of these medicines and they start having hot flashes. It may mean that we have to change your antidepressant therapy to both treat depression and hot flashes. There's also some side drug interactions between antidepressants and tamoxifen, if that's the endocrine therapy that you're on. So it's important that we choose wisely. Gabapentin, which is a medicine traditionally used for peripheral neuropathy, which is that numbness and tingling that we can get, can also work for hot flashes. In the studies that were done looking at gabapentin, however, it seemed that either gabapentin worked for somebody or SSRIs worked. That if SSRIs aren't working, switching to gabapentin is often a really good option, but if SSRIs are working, adding gabapentin may not add much. Gabapentin can be somewhat sedating, so I clinically like to use it for my patients with nighttime predominant hot flashes, because we can sort of kill two birds with one proverbial stone, because we'll make them a little bit sleepier at night too. Clonidine is a medicine that's been shown effective in hot flashes. I find the most effective strategy is the patches, because you get a little bit less blood pressure fluctuation, which is actually what Clonidine was designed to treat. And then you get that longer, stable delivery of the medication, which can better treat your hot flashes. Lastly, oxybutynin, which is a medicine to treat bladder spasms, has been shown to treat hot flashes, particularly refractory hot flashes, so hot flashes that did not respond to the antidepressants or gabapentin. Sometimes the punishment doesn't fit the crime, though. Oxybutynin can cause a very severe dry mouth. And although it often will control my patients' hot flashes, sometimes they end up deciding that the dry mouth is worse than the hot flashes and they'll stop taking it. Next is joint pain. Here's our friend, the Tin Man. Patients on anastrozole, letrozole, and exemestane can feel very stiff, less likely tamoxifen. And it's important when we're thinking about what that could be that we don't miss metastatic disease, especially if somebody has been on those medicines for a long time without joint pain and all of a sudden they're developing that symptom. Treatment options include physical therapy, acupuncture, and exercise. I know patients always, I think I'm crazy when I tell them that they need to start exercising when they're complaining to me that they hurt. But exercise has been shown to significantly reduce the rate of the risk of joint pain and has a lot of other benefits in our long-term breast cancer outcomes. So it should be a part of the treatment. You'll note I included drug holiday there, which will tailor nicely with Anne's conversation next. There's evidence that stopping the medicine for 1 to 2 weeks sometimes can let the symptoms abate, and then re-challenging with the medicine for some patients, it won't come back again. So that can be a strategy, although I wouldn't be doing repeated drug holidays because we want you on your medicine so that it can work to treat your breast cancer, not repeatedly off your medicine. Switching therapy, so if you're on anastrozole, let's say, and we switch you to letrozole or vice versa, will stop the joint pain for about 40% of patients. That works in any direction that we switch the medicines, which is really interesting. So just switching from one to another, since all the aromatase inhibitors have the same efficacy, they all work the same to treat breast cancer. Switching is a great option. Duloxetine, which is Cymbalta as the brand name, has been shown effective to treat. The recommendation is to titrate the dose up slowly. There is a holistic supplement called Tart cherry extract, and pictured there is one of the brands that I've had good luck with. Tart cherry extract is a juice. It's very thick. It's like maple syrup. And the recommendation is to put 2 tablespoons in a glass of water at bedtime. Tart cherries are basically nature's ibuprofen. So if you are drinking tart cherry extract at bedtime, a lot of patients will experience less joint stiffness in the mornings, especially. That's been proven in studies. And I tell patients, although the tart cherry extract can be pricey, it's like $20 or $30 for that big bottle, you're using 2 tablespoons at night, so it lasts a long time. And if it works for you, it's awesome because, hey, you're having less pain. And if it doesn't work for you, all that happened was you drank some juice, and then you should stop buying it. The next is vitamin D. There was a study looking at very high dose weekly vitamin D that showed a reduction in joint pain and an improvement in joint function. For patients that choose the high dose vitamin D, I would recommend monitoring blood work because you can get your calcium out of whack with a dose that high of vitamin D. Cardiomyopathy, here's our Tin Man. He just needs a little, he just wants a heart, right? But maybe he got a little too big of a heart. So cardiomyopathy is when your heart muscle doesn't squeeze or contract as hard. There's lots of other things that can happen to our heart from cancer treatment. The big culprits for cardiomyopathy are our HER2-directed therapies and anthracyclines, and especially when those things are used in combination. So it's like a 1 + 1 = 3 phenomenon, where when we use Herceptin plus adriamycin, the risk is very, very high. There's newer evidence that suggests that that should never be done, that most breast cancer can be safely treated, HER2-positive breast cancer can be safely treated without combining the 2 agents. It's important that we don't forget that common things are common, and that for patients with new onset signs or symptoms of heart problems, that we make sure that they don't have a blood clot or a heart attack. Treatment options include primarily prevention. We do echocardiograms, which is an ultrasound of your heart to make sure your heart is healthy before we start. Interestingly, exercising before starting your cancer treatment, like when you're going to be diagnosed with breast cancer, is effective. So even just from the minute you're diagnosed, starting an exercise program can reduce the risk of developing cardiomyopathy on cancer treatment. Taking lisinopril, which I'll talk about as a treatment, can reduce the risk of developing cardiomyopathy. And then for people that do develop heart strain while they're on treatment, taking a break from the treatment while they're on it, letting their heart function recover. Actually, with the HER2-directed therapies, then we can re-challenge them with those medicines, and they're not very likely to have their heart it's safe to re-challenge them. It doesn't cause the cardiomyopathy to come back. With anthracyclines, we typically cannot re-challenge. For patients that do develop heart strain, we treat with ACE inhibitors and beta blockers. For patients in the metastatic setting, there's an FDA-approved drug called dexaroxazone, which is used in combination with the doxorubicin as we get to that maximum dose so that we can keep using the medicine longer. Because in the metastatic setting, if a medicine's working for you, it's a shame that we need to stop it because we're approaching a heart unsafe dose. So we can combine this heart protective medicine to try to spare the added risk to the heart. The next treatment is peripheral neuropathy, next episode of collateral damage is peripheral neuropathy. The culprits are really the taxanes. So paclitaxel, docetaxel, nab-paclitaxel, eribulin is sort of a taxane derivative, and then the platinum agents, so carboplatin and cisplatin. Again, it's important that we don't miss other things that can cause peripheral neuropathy, like diabetic neuropathy, carpal tunnel syndrome, vitamin B12 deficiency, or other spine diseases, including, unfortunately, metastatic disease to the spine. Treatment options include, again, prevention. Exercise can decrease the risk of developing peripheral neuropathy. Similarly to the cardiomyopathy, exercising before treatment decreases the risk of developing peripheral neuropathy. Cryotherapy, which is my big fancy doctor word that means icing your hands and feet before your chemo or as that chemo agent is running in, decreases the risk of developing peripheral neuropathy, as does compression. Below, you'll see pictures of some of the fancier ice gloves and ice booties you can purchase. Those are all from Amazon. I've seen patients come up with their own fancy man-made versions using ice and Ziploc bags, which is fine too. The concept being that if your hands are cold, there's less blood delivery, and if there's less blood flow, there's less damage, those little tiny nerve endings from less chemo delivery to those little tiny nerve endings. And I think that the risk of having cold hands, although it sounds like misery to sit with my hands on ice while my chemo's running in, if it prevents me from a side effect that is often not reversible, meaning permanent, it might be worth it. Treatment options are gabapentin and duloxetine. They do not make the peripheral neuropathy go away, but they can ease the pain of the peripheral neuropathy. For patients starting to develop peripheral neuropathy on treatment, we can hold the dose of their medicine and see if their peripheral neuropathy starts to get better, and then lower the dose of the medicine to see if we can prevent it from coming back as we restart. On the column over here, you'll see this is just from UpToDate, which is sort of this one-stop shop medical information website that doctors use. And this is the article on peripheral neuropathy, and it says agents which are not recommended. And you'll see this huge list of things. This is my way of saying, we have really tried everything for peripheral neuropathy and very little helps. I have patients who have this toxicity and they say, well, what about this? What about this? What about this? Because Google and a variety of practitioners will recommend all sorts of things, and they've consistently not been shown effective. And so this is, I think, the side effect out of all the things that we do to patients that bothers me the most, because there's little that can be done to help it. Chemo Brain, as we lovingly call it, here's our straw man wishing for a brain, is a side effect, honestly, of all cancer treatment. There's evidence that Chemo Brain even starts from the biopsy, which really tells us that it's stress brain. And it's that forgetfulness and difficulty concentrating and fog that comes with cancer treatment and cancer diagnosis. Obviously, there's different levels of Chemo Brain amplified by the dose and duration of chemotherapy, the length of surgery, whether or not you received radiation and whether or not the radiation went to your brain, all of which impacts the likelihood and severity of Chemo Brain. It's important that we rule out metastasis to the brain and strokes, as well as other concurrent disorders that would need to be managed that can add to that sensation. So things that I'm thinking about when somebody is talking to me about their difficulty with Chemo Brain is making sure that if they have insomnia, that we treat it. If they have depression, we treat it. If they have attention deficit disorder that's not previously been diagnosed, that we treat it. If they have anxiety, that we treat it. If they have malnutrition, meaning either they're not eating enough or they're not eating healthy, that we address it. Things that have been shown effective are meditation. Developing a meditation practice is a great way to help improve your mind's ability to focus and your mind's ability to tune out that collateral noise that is a part of life in 2021. Exercise, I feel like a broken record saying exercise, 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 but exercise can really improve concentration. Cognitive behavioral therapy, and brain training programs. So there are very formal brain training programs. The poor man's version of a brain training program is things like crossword puzzles and Sudoku. It is better if those things are done with pencil and paper rather than on a screen or a tablet, which is actually destructive for that chemo brain sensation. There is some limited data for medications like modafinil and methylphenolate, and dinazepril as well. For nausea, lots of culprits, all of our cancer treatments. It's important that we don't miss bowel obstructions or infections or hypercalcemia. And really what I want to say about this without going into a lot of details about all of these medications, because I know I'm running long on time here, is that there are so many medicines available to treat nausea. And we just need to talk to our treatment team, our medical oncologists, nurse practitioners, and explore what else can be added, what can be substituted to get us to a better place where our nausea is controlled. Because just because ondansetron is our go-to doesn't mean it's the right drug for you. And there's lots of things that we can mix and match to get a better treatment. And sometimes that's the IV stuff that we're mixing in that cocktail that goes in before the chemo starts. There is an FDA approved product called a relief band, which has little metal conductors that sit against your wrist and put an electrical stimulus that then goes down and kind of shocks your arm, but it stimulates the vagal nerve and can decrease chemo-induced nausea. And it's a non-medicine way to control nausea for people that just don't feel like they can add one more medication to their mix. I actually use relief bands for my motion sickness, and they're a wonder. I am going to skip constipation in space of time and go to fatigue. For fatigue, really everything and anything is the culprit of fatigue, the cancer itself, all of our treatments, life. And it's important that we don't miss other things, sleep disorders, anemia, thyroid dysfunction, depression, opioid-related sedation for people on pain medicines from metastatic disease. And the treatment is really focused on identifying any underlying conditions and treating those. If there's depression, treat it. If there's anemia, treat it. Stimulus control. Stimulus control means that, like, basically you live your life on a schedule. I think of it as like going back to kindergarten, where like you wake up at this time and this is the time you go to school and this is the time you eat your graham crackers and this is the time you have lunch. That when you have fatigue, focusing on scheduling really can improve your ability to kind of get through that day. And that's been proven in studies. It's weird that that's the sort of thing doctors study, but here we are. Exercise, again, has been shown. Mindfulness, meditation, yoga, cognitive behavioral therapy. Again, there's some evidence for methylphenidate, dexamethasone. Antidepressants are shown effective even in patients who they don't think are depressed. Only in end of life, there's evidence supporting glucocorticoids, and then there's also some evidence for ginseng. I do want to mention that ginseng has a lot of medication interactions, so before trying ginseng for cancer-related fatigue, make sure you check with your oncologist about any interactions with what you're potentially taking, because we don't ever want to put you at risk for complications or your medicine's not working because of a supplement that we start. The key takeaways from all of that is that a lot of really terrible things happen on this yellow brick road of cancer treatment. And what I hope is that everybody feels like as partners between you, the patient, and you, the oncologist or healthcare professional, that we can find these ruby slippers that work toward the common solutions. There's lots of times that we can modify the dose to get better side effects. There's lots of holistic approaches that we can use. There's lots of medications that we can use, but the key is to make sure that we're communicating and talking about it so that we can get you the solutions that we need for the side effects that you're experiencing. Thank you all for your time. I hope we'll have lots of time for questions at the end, and I'll be answering some in the chat. And I'm going to pass it back to Michelle, who is going to introduce Anne.
Thank you so much, Dr. Graff. As always, a plethora of information and resources for our patients. So yes, our second panelist is Anne Loeser. Anne was diagnosed with early stage breast cancer at age 39 and with MBC 18 years later. On both occasions, her symptoms were misdiagnosed, an experience that subsequently transformed her into a patient advocate, researcher, and author. Anne's book, The Insider's Guide to Metastatic Breast Cancer, which she's told me is available on Amazon, has been described by Dr. Mark E. Burkhardt as a labor of love in which deep knowledge and years of experience are shared in an organized and accessible format. Every drug, every breast cancer subtype, every scan, every site of disease, it's there. The guide is updated when new treatments are approved and key research findings are announced, so the information therein is always current. Anne is a member of the Metastatic Breast Cancer Alliance, a research grant reviewer, and a project lead graduate. Her concerns about patients' treatment-related side effects motivated her to establish the patient-centered dosing initiative, a movement made possible through the collaborative efforts of patient advocates and medical professionals who share a passion for improving patients' lives. Thank you, Anne, for joining us today.
Very much for this opportunity to speak. I'm going to go ahead and share my screen. Can everyone see that patient-centered dosing front page?
Yes, we can see that.
Terrific. Well, before I begin, we heard from Dr. Graff's excellent presentation about the various side effects experienced by patients living with cancer on their treatment. And we've heard about the strategies for mitigating them. What has not been mentioned is the reason why these drugs are so difficult to tolerate and what, if anything, is being done to address that. And that is where patient-centered dosing comes into play. The cancer drug dosing paradigm that has been with us for at least 70 years can be summed up in 3 words. More is better. Dose escalation methods used in phase 1 clinical trials were initially developed in the era of cytotoxic or chemotherapy drugs. All along, it's been assumed that both efficacy and toxicity increase with higher doses. And in fact, phase 1 clinical trials measured toxicity as the primary endpoint for the single dose to be further studied. That single dose is referred to as the recommended phase 2 dose, or RP2D, and that is usually based upon the maximum tolerated dose, which is the highest dose of a drug that does not cause unacceptable toxicity. But how true is this paradigm? Well, some of us may remember in the 1990s, more than 41,000 breast cancer patients underwent a procedure called high-dose chemotherapy and autologous bone marrow transplant in the hope that these really high doses of drug would cure them of their disease. But in fact, in the year 2000, the New England Journal of Medicine reported the results of a major randomized trial of this nature for metastatic breast cancer patients and determined there was no survival advantage when compared to standard dose chemotherapy. So that is when the paradigm that more is better began to be seriously questioned. As you could imagine, there are limitations of phase 1 dose escalation. It's based upon the premise that the higher the toxicity, the greater the efficacy. It has small fixed group or cohort sizes. Typically in a phase 1 dose escalation trial, 3 patients are enrolled in the lowest dose. If they do well, another 3 patients are given the next highest dose, and so forth until dose-limiting toxicities force a stop and the maximum tolerated dose is reached. Furthermore, phase 1 dose escalation does not take into account long-term treatment-related side effects such as neuropathy that Dr. Graff was talking about. It ignores levels of drug efficacy. It's not entirely relevant for targeted therapies where clinically significant adverse events may not occur at doses above the optimal biological dose. And the optimal biological dose is simply the lowest safe dose that's associated with biological efficacy. Finally, but very importantly, real-world patient responses differ from those of clinical trial participants because the latter are subject to rigid inclusion and exclusion criteria to get into the trial, but real-world patients are not. And also, as we know, each of us is unique. So why do dosage levels even matter? Well, unlike early-stage breast cancer patients, people living with MBC are treatable, but they're not curable, and most will remain on some sort of treatment for the rest of their lives. At the beginning of each new treatment, they are usually prescribed what's called the recommended starting dose, and that dose is often based on the maximum tolerated dose, which usually triggers the most and the worst side effects. As a result of these side effects, patients with MBC have been known to visit the emergency room or hospital, be rendered incapable of receiving treatment on schedule. And of course, that's true of some people with early stage breast cancer who are having difficulty with their treatment. They can experience a reduced quality of life. And although more data is needed, recent evidence of some drugs suggests that lower allowed doses may be as effective as the RSD with less severe side effects. In this context, an allowed dose refers to any dose on the drug package label. When you open the label, you'll see the RSD right up front, the recommended starting dose. Sometimes that's the only dose the drug is available in. But in many cases, lower doses are listed later on in the package label, and those lower doses are typically given when the patient is having trouble with a recommended starting dose, so they could get a dose reduction. Bringing it together, an allowed dose is any dose that's listed on the package label, and in some cases, it may only be one. Lower doses may enable patients to remain on a working therapy longer and miss fewer treatments. Dr. Graff talked about a treatment holiday, but also in the case of patients, some of them have to drop a therapy because it's too toxic for them, even when it's working, and that is very problematic. So these issues gave rise to the Patient-Centered Dosing Initiative, or PCDI. And although the principles established by the PCDI's patient advocates and medical oncologists were developed with the intent of transforming how patients with MBC are treated, they may be applicable to patients with other types of cancer. These are our patient advocates. Probably some of the names and faces may be familiar. And this is our all-star board of medical oncologists on our advisory board. Again, some familiar names and faces. Our objectives are pretty simple. Our mission is to enhance quality of life while maintaining therapy effectiveness by enabling patients with MBC and their doctors to identify the optimal allowed dose of treatment based upon each patient's unique physical, circumstantial, and psychological factors. In a nutshell, we are giving birth to a new paradigm. Instead of prescribing the recommended starting dose at the beginning of each new treatment and eventually reducing the dose when side effects occur, we are urging patients and doctors to discuss the patient's attributes and jointly decide on the best allowed dose for that patient at that time. What are these attributes or criteria that we're talking about? We've identified 9 patient-centered criteria. The first is the patient's personal goals and wishes. The second is their performance status, other illnesses they may have, their agility, age, and so forth. History of side effects from other drugs. Some patients tend to be more sensitive to drugs than others. What are their current and historical blood counts? Is the disease aggressive or indolent? Is there organ dysfunction or central nervous metastasis? What is their body mass index? This is one that I'll go off on a tangent for a moment about. I recently read that the average body mass index of an adult American female is 29.6. So in phase 1 clinical trials where we have adult American female participants and the dose needs to be identified, we can surmise that the approximate average BMI of these patients is around 29.6. But as we know in the real world, some people have a much higher BMI, and some people like me have a much lower BMI, mine's 17. And yet, in so many drugs, the dose is determined by phase 1 clinical trials on average sized patients. And many drugs do not adjust for BMI. An example is the CDK4/6 inhibitors like Ibrance. What is the financial situation of the patient? So if they need additional medications, and Dr. Graff gave us quite a list, or if they need a referral to a specialist for side effect mitigation, can the patient afford that? And finally, and very importantly, what is the availability of the patient's at-home care? So if we can surmise for a moment that there's a wheelchair-bound patient, there's no one at home to care for them, is it really in that patient's best interest to give them the highest dose of a drug that will precipitate the most uncontrollable nausea or diarrhea? The PCDI launched a patient survey for individuals living with metastatic breast cancer and an oncologist survey for US-based doctors with experience treating patients with MBC. The oncologist survey results are in red, and we'll see everything as far as the results in a second. We had an overwhelming number of responses, 1,221 to the patient survey and 119 responses to the oncologist survey. The purpose of both surveys was pretty much identical. It was to understand the prevalence and severity of patients' treatment-related side effects and the level of communication between doctors and their patients when these occurred. And we wanted to understand whether patients and their doctors would be willing to speak about patient-centered attributes when it came to dosage. We wanted to hear this from the patients as well as from the doctors, because sometimes the feedback can be different, as we know. What we learned is that the overwhelming majority of patients, 86%, had experienced at least one bad treatment-related side effect. The majority of oncologists underestimated that. They felt that less than or equal to 60% of patients had reported a bad side effect. Of the patients who experienced a side effect, 1 out of 5 had to visit the ER or hospital. The oncologist estimate was close to 15%. More than 2 out of 5 had to miss at least one treatment due to side effects. The oncologist estimate was close at 37%. Of the patients who experienced a treatment-related side effect and reported it to their doctor, 66%, 2 out of 3, received a dose reduction. How did they feel on the dose reduction? 83% indicated that they felt better on the lower dose. At some point or another, 87% of the oncologists indicated that they had started patients at a lower dose for various reasons. Sometimes there's a contraindication to the RSD, or the doctor just felt their patient might not be able to tolerate the standard dose. 60% of the oncologists noted that patients starting on a lower dose felt better than patients starting on the standard dose, and 59% also noted that efficacy was similar to the standard dose. We asked the patients and oncologists whether they subscribe to that paradigm we talked about of more is better. And in fact, we learned that 53% of patients and 85% of oncologists do not believe that a higher dose of a cancer drug is always more effective than a lower dose. Very interesting that majority of oncologists do not subscribe to that paradigm. And finally, we asked the patients and the doctors whether they would be willing to discuss dosing options based upon the patient's attributes. A phenomenal majority of both, 92% of patients and 97% of oncologists said yes, they would be willing to engage in these discussions, which is wonderful. In June of this year, the PCDI had the privilege of sharing the results in an oral presentation at ASCO's 2021 worldwide meeting regarding the NBC patient survey that we just walked through. 5 months later, in November, the FDA came out with this announcement. It is loud and clear from our patients that the drugs are too toxic. Patients deserve a more tolerable dose. And that is from Dr. Atiq Rahman, FDA Division Director, Friends of Cancer Research Annual Meeting in November. I'll pause here and say what we are witnessing as we speak is the demise of the old paradigm of more is better and the beginning of a new paradigm, optimal is better. Former dose escalation methods used in phase 1 clinical trials are being revised. It is no longer assumed that efficacy and toxicity increase with higher doses. And furthermore, phase 1 clinical trials will measure multiple endpoints to determine at least 2 doses, not 1, but at least 2, to be further studied, and neither of them has to be the MTD. In an article in the New England Journal of Medicine on October 21, the FDA wrote this: sponsors should carefully evaluate exposure response, efficacy, and safety data from early trials to inform dose selection rather than automatically selecting the maximum tolerated dose. Both the FDA's and PCDI's approaches are patient-centered with regard to dosing. They are both complementary. There's the front-end aspect whereby dosage is identified in clinical trials. And then there's the back-end situation after the drug's approved and the patient is sitting with their doctor in the clinic. And that's where patient-centered dosing remains important, because approved drugs currently on the market will continue to be prescribed based upon the MTD, because that's what they were approved upon. It will take time for drug development to leverage the new paradigm. We know how long drug development takes. Patients' responses in the real world, as we said before, differ from those of patients in clinical trials due to they are not subject to rigid inclusion and exclusion criteria. And finally, we will always be as unique as our fingerprints. Both the FDA's and the PCDI's approaches are beneficial for patients. As a result of fewer toxicity-related side effects, patients may have less need for acute care, miss fewer treatments, or need a treatment holiday, as Dr. Graff mentioned, potentially remain on a working therapy longer rather than dropping it due to toxicity, and potentially having a better quality of life. Possibly, they may even live longer. I've given you a lot of information, but in the end, what could we patients do? We could discuss patient-centered dosing criteria when beginning a new treatment, even if we have early stage and not metastatic breast cancer. We can make the doctor aware of personal wishes and priorities throughout our treatment because these could change. If you're experiencing treatment-related side effects, speak with your doctor about the options to relieve them. We saw a lot of these in Dr. Graff's presentation. And they could include dose reduction, changing frequency, trying a different drug manufacturer. The reason for this is different drugs can have different fillers, and some people can be sensitive to some fillers, but not others. Obtaining medication for relief, switching treatment, or getting a referral to a specialist. Make a decision with your doctor about how best to mitigate your side effect, but never reduce the dose or alter anything about your treatment independently. Always discuss your options with your doctor before making any changes. If you're interested in reading more about dosages and the Patient-Centered Dosing Initiative, we have 9 articles listed here. And last but not least, I want to thank you for your attention. Invite you to visit therightdose.org, which is the PCDI's website. Or if you have questions or comments, email us at info@therightdose.org. I'll open it up for questions. Thank you very much.
Thank you so much, Anne. We are going to take time to answer some questions. We had about 3 questions previously submitted before the webinar started. In addition, we do have a Q&A box. So I know Dr. Graff and Teresa have been answering some questions on the back end in the Q&A. So if you have a question that you would like Dr. Graff or Anne to answer during this webinar that you think that would be beneficial for others participating to learn, please submit it in the Q&A. But I will start with the previously submitted questions. Should I be concerned about a yearly MRI with contrast?
I think the answer is no. MRI, the contrast that we use with MRI does have some concern that it may accumulate. And so people getting excessive MRIs, the gadolinium, the dye that we use, there's concerns about. For people doing them once a year as a part of a high-risk screening situation, the benefit of the high-risk screening probably outweighs the risk of accumulation. Most people that are participating in a high-risk screening program also probably aren't going to participate in a high-risk screening forever. There's probably a strategy there. So I would have that conversation with your care team as well.
Thank you, Dr. Graff. What is the relationship of breast cancer treatments, chemo, radiation, etc., where we must have quote unquote strong hearts to cope, to developing heart issues some years later on in survivors, such as AFib, irregular rapid heartbeat? Are there any longitudinal studies around this?
And you should feel free to jump in on any of these questions that you want. One of the problems with long-term, it's always really hard to collect data that looks at what happens 20 years down the road, 30 years down the road, because then all this other noise about the general health of us as an American society gets in the way of the data. I think that because of, I'm choosing my words carefully. Another complexity of those sorts of studies is that when you look at 20-year follow-up, you're looking at data that was collected in 1980, and the way that we've treated breast cancer has evolved so much in that time frame. It's really hard to say that's the outcome of today's treatment because it's a lot different. But that said, exposure to anthracyclines definitely can dilate the heart, and having dilation of the heart can increase the risk of arrhythmias longitudinally over your life. Having left-sided breast radiation increases the risk of having left-sided coronary artery disease. Having coronary artery disease also increases the risk of having atrial fibrillation. One of the biggest predictors of atrial fibrillation is things like undiagnosed sleep apnea, which increases as we get obese. We already have been acknowledged that breast cancer treatment can lead to weight gain. So it's also interrelated. It's hard to say breast cancer's got nothing to do with it. So my guess is there's probably a link. But to the best of my knowledge, there's no clear study that says this drug, this treatment, this stage of disease increases the risk of atrial fibrillation.
Thank you. Why is there so little data about and no cure for chronic cancer-related fatigue, and how can research be improved and sped up?
It's because it's so multifactorial. It is part of the problem. Cancer-related fatigue is as diverse as cancer, as breast cancer treatment, as we are as humans. And so it's hard to design cures for it. Because like when I was talking about the causes and the things that we have to evaluate, we need to treat underlying conditions, depression, nutrition, exercise, other drains on our energy stores, age is a function. And so it's really hard to find like with like and find solutions. And what would you say to that?
I don't really have a whole lot to add. That's not something I've looked at in depth. I think you covered it.
Great, thank you. And then we have a couple submitted questions coming in. Can you share the affiliation of the 119 oncologists, for example, any oncologist from MD Anderson? I'm thinking this was for the survey.
Yeah, the majority were from academic institutions, and I think it was like 37% were community-based oncologists. So we didn't ask the specific institution where the oncologist worked. We just asked whether it was an academic practice or a community-based practice. And the majority were academic. That was a good question.
Great.
One of the questions was asking if I could share the constipation slide that I jumped over. So I'm throwing it up while you keep going through the questions.
Great, thank you. What is the lowest dose of Piccray that is effective? Am I pronouncing that correctly?
Honestly, I would have to look it up. Piccray, I know Piccray has at least 3 dose reductions that were studied in the clinical trial. And I would say that you can dose reduce all the way down to the lowest one and still be effective. Piccray is a hard drug to take. It has a lot of side effects. And based on this question, I'm assuming the asker knows that. And so I would keep dose reducing and not feel bad about the fact that you needed a dose reduction.
Yeah, and I could add to that. On our website under resources, we have a list of studies about drugs for which we've been able to find efficacy related data of lower doses. And the only drug that I came across where the lowest dose was not as effective as the RSD of the limited drugs I was able to find efficacy data about was Piccray, where the lowest dose was not quite as effective in terms of PFS as the top dose, the RSD, and the first dose reduction. But the first dose reduction was as effective as the RSD. And by the way, that is a pitch. Go and take a look at rightdose.org. Look at the resources section and look at the studies. We have chemotherapy drugs that we've identified. CDK4/6 drugs. So please, by all means, you're welcome to look. We just don't have enough data about lower doses of every drug.
The doses of Piccray are 300, 250, and 200. So 200 is where you can go.
Thank you both. The next question we have, even though I had a high level of hand-foot syndrome, I was afraid to dose reduce Exloda due to previous progression. How can we educate patients that lower dose can work?
It's a really good question. I'll take this first, and then Dr. Graff, please feel free to chime in. Patient education is so important, but so is oncologist education about these. And one of the things that I mentioned before is we just don't have enough data about the efficacy of lower doses. So if a patient experiences very toxic side effect, and they're talking about a dose reduction to improve their quality of life, we think it's always, a trade-off. They will want to know how effective a lower dose is. And in some cases, we could show them that on our patient education flyers, which would be developed next year. And in some cases, we just don't have the data. And one of the things the PCDI is intending to do next year is to approach the different industry or drug companies to try to get the data about already approved drugs and the efficacy of their lower doses. Dr. Graff, might you want to add anything?
I think that was the whole answer. I think the solution is that we just talk more. I engaged with enough patient advocates in that patient advocacy space that I know that not everyone feels like they have a robust relationship with their oncologist that they can engage in these dialogues. And I know that not all of my colleagues communicate as effectively as I wish that they would, but it's so important that we have these conversations where patients understand that we are offering the dose reductions because we believe that they are still safe and effective. I'm not ever going to offer somebody cancer treatment that I don't believe is going to work for them. And so if your cancer specialist is saying, I think we should lower your dose, they believe that that is going to make your side effects better and not jeopardize your cancer outcome.
And then that's a great point. And the other thing is, remember, the FDA is changing the paradigm. That these drugs were based on the maximum tolerated dose, which didn't take efficacy into account until phase 2 and phase 3 trials. And by that time, the MTD had already been established. Now they're saying, whoa, let's take efficacy and safety into account and determine that at least 2 doses from phase 1 trials to be further studied. So they themselves are backing away and encouraging industry to back away from this high is better paradigm that we've all lived with for so long.
Thank you. This one is specific to Dr. Graff. With the tart cherry extract, what is the dosage? It comes in liquid, capsules, and gummies.
I've had better luck with the liquid than the capsules, but I have patients on both. So feel free to experiment with what works for you. Obviously, I realize that for most people, a capsule is just easier to take than what do you do walking around with your juice in your pocket when you're traveling or something? Your flask of tart cherry juice. It is 2 tablespoons of tart cherry extract in a glass of water at bedtime. The tart cherry extract is very tart, so you can't just suck it off the spoon because your whole face will pucker in and you'll writhe around on your floor in tart cherry death, which won't make your joints feel better. So you have to mix it in the water.
Good to know. And then we are pretty much out of time, but I will have you both answer this last question. What do you think about metronomic dosing? Is it the future for current IV drugs? Easier to reduce dose? Question.
We just don't know enough yet, I think is the quickest answer in our time crunch. Metronomic dosing has been looked at better in other cancers than breast cancer. specifically head and neck cancer, I think is probably ahead, which honestly, the chemotherapy we give head and neck cancer is barbaric. And so it may have a future, but in breast cancer, we don't have enough data that at least me clinically feel safe moving away from medicines that I know can improve survival to dosing and schedules that I can't safely say will do the same.
Yeah, and I would love to see more studies. Basically, metronomic dosing is a lower continuous dose, so there's no treatment breaks, and it's generally easier to tolerate. But unless there's robust data, obviously, we can't really bring it to market. So more studies are definitely needed, but I believe it shows promise.
Okay, great. Well, thank you again to Dr. Graff and Anne for joining us today and for presenting such helpful information. Unfortunately, we are out of time. If you had questions that were not answered today, or you think of questions later and would like to get in touch with the foundation about what we presented today or any of our research initiatives, please email info@drdrsusanloveresearch.org. Today's webinar has been recorded and it will be soon posted on our website. I did add the link to our website in the chat box. It is under Newsroom on our website. It's easy to find all of our past webinars there. And then I encourage you to visit our website if you're interested in learning more about the foundation or making a donation in support of our research. I'd like to thank each of our panelists again for joining us today, and for all of you for being a part of today's webinar and submitting some wonderful questions. And I hope all of you are staying safe and healthy, and I wish you a wonderful holiday season.